Hello and welcome to my non-medical prescribing presentation. Case study is Mrs. A, a 79-year-old female who presented with a painful toe. Past medical history, MI, ischemic heart disease, heart failure with preserved ejection fraction, chronic renal failure and TIAs. On examination, the right metatarsal phalangeal joint was swollen, red, hot and painful. She'd had a rapid onset overnight and had reduced range of movement. I first ruled out other diagnoses, such as septic arthritis. She was apyrexial, and she would have had complete immobility of the joint on active and passive movement if it was septic arthritis. Osteoarthritis was ruled out. That was due to the acute onset over a few hours. I concluded that the diagnosis was gout based on presenting symptoms. The American College of Rheumatology report that the gold standard for diagnosis of gout is evidence of urate crystals in joint fluid, which is not practical in primary care, so NICE state that as long as there is no suspicion of any other conditions, it's sensible to diagnose gout. Gout is an inflammatory rheumatological condition characterized by a raised uric acid level. It has an increase in incidence today due to its links with lifestyle and dietary excess. According to NICE guidance, gout can be diagnosed when pain, redness, warmth and swelling are present. The metatarsal phalangeal joint is the most common joint affected, although other joints can be affected. A peer-reviewed study concluded that cardiovascular disease, kidney disease and diabetes increase the occurrence of gout and can be an independent determinant of premature death. Mrs. A had a long cardiovascular history as well as chronic kidney disease. A study published in the Lancet provided a summary of relevant literature collected from Cochrane Library and Medline. And a similar study, although much older, used the same search terms, and they both led to the conclusion that the basic symptoms to diagnose gout haven't changed. Due to its at times atypical presentation, there isn't a standard diagnostic tool that all experts can agree on. A randomized controlled trial in 2018 attempted to establish whether a gout activity score had any validity. They randomized patients to either continue under the care of their GP or to have nurse-led care following a protocol which included treat to target for levels of uric acid. The origins of this gout activity score originate from a 2016 study which attempted to qualify disease activity in gout and lead to a tool that could be used in primary care. Each subsequent testing of this activity score has concluded that much larger samples are needed before the score could be applied across all settings. Likelihood ratios for diagnosis increase for subsequent attacks. And a multinational literature review in 2014 gathered the opinions of rheumatology experts of a non-systematic review of the evidence for diagnosis and management of gout. Each expert rated the evidence from the selected studies. The implications of practice are difficult to demonstrate in primary care, as all the experts involved were hospital-based, so the focus was on more invasive diagnostic tests such as joint aspiration, ultrasound and CT scans. The level of evidence used to determine this conclusion was based on level 2B evidence, which according to Harris, Taylor and Jackson means that the evidence is from at least one quasi-experimental study, which indicates the data only suggests the guidance and should be used in caution when applying it to practice. Prevalence rates are similar in the developed world due to links with diet and lifestyle. It's estimated around 3% of people will develop gout in their lifetime. Despite this, gout is frequently mismanaged in primary care, with many patients receiving suboptimal treatments. I decided to prescribe colchicine. This is the recommended first-line treatment in local guidance. The main aim of treatment involves inhibiting the processes which lead to crystal-induced inflammation. One of the main documented actions of colchicine is the inhibition of neutrophil chemotaxis, and colchicine dampens down the inflammation by reducing recruitment of neutrophils to inflamed tissue. This process occurs at very small doses of the drug, and large doses have shown to be toxic to tissues. Colchicine has a very narrow therapeutic window, and when prescribed acutely for gout, up to 23% of patients report diarrhea as the main adverse event. It is primarily excreted by the liver, with about 20% eliminated via the kidneys when a patient has normal renal function. A literature review of the actions of colchicine found only one randomized, double-blinded, placebo-controlled trial. Almost 200 patients were randomized to either high-dose colchicine, low-dose colchicine, or a placebo. High-dose and low-dose groups showed almost equal positive results, although the high-dose group reported more gastrointestinal adverse effects. The researchers concluded that the most effective gout treatment was low-dose colchicine of 500 micrograms up to 4 times per day. And a systematic review in 2017 concluded that colchicine significantly reduces pain at 24 and 48 hours. Apart from the avoidance of drugs which adversely interact, dose reduction should be considered in any patient with hepatic or renal impairment. The BNF suggests a dose reduction of 50% in EGFRs under 30. Other research studies advise a 50% reduction if the EGFR is under 50. Mrs. A's EGFR was 28 and she was known to be chronic stage 4 kidney disease. The dose I prescribed, with agreement from the patient, was 500 micrograms twice a day. The patient was given clear information to space the doses and take them in the morning and at bedtime. She was advised on potential side effects, primarily gastrointestinal upset. I checked her understanding of this before the end of the consultation and ensured she knew to contact out of hours if there were any issues overnight. Professional responsibility and accountability. So the shared decision reached between me and the patient was for her to take it for 72 hours initially. If she experienced any adverse events, she was to contact me, and I arranged a follow-up appointment in 3 days. Professional responsibility means having a clear rationale for a prescribing decision, considering any alternatives before prescribing, ensuring the patient has sufficient information, being cautious when prescribing for older people and people with renal and hepatic disorders, ensuring timely reviews are carried out, being aware of changes to formularies, communicating clearly to patients and other professionals, keeping accurate records, and reporting adverse events via the yellow card scheme. Mrs. A had poor renal function, so her colchicine dose was reduced accordingly. She was also given appropriate non-pharmacological self-care advice to rest and use ice on her foot, to relieve pain and swelling, and also to use simple over-the-counter analgesia. Prescribers are accountable for their own practice, and all registered nurses need to comply with the NMC code, and as prescribers comply with the RPS framework. Under these frameworks, prescribers must document all decisions and actions, adhere to local policies, keep up to date with their own knowledge and competency, only prescribe within their competency area, only prescribe for a patient they have assessed, and ultimately do no harm to the patient. It is essential to use only validated sources of information and be able to critically evaluate other information sources. Legal implications. As an independent prescriber, you are accountable for your own prescribing decisions under the RPS framework. And equally, one of the most important pieces of legislation is the Medicines Act of 1968. All prescribers must comply with this law, and a breach of responsibility under the law can lead to prosecution. The ultimate aim of any prescriber is to be safe and effective. To achieve this, it's imperative to ensure you only prescribe within your scope of prescribing competence. Mrs. A rang to speak to me 2 days after commencing colchicine to report that she'd had diarrhea. She reported that it had been frequent and unrelenting and was having a severe impact on her life. I advised stopping the colchicine that day and arranged a visit to review her that afternoon. On review, she had had clear improvement in her gout symptoms and her pain had reduced. We agreed that the current gout attack had finished, and as per NICE guidance, I arranged for her to have a serum uric acid level checked in 4 to 6 weeks to guide prescribing of prophylaxis treatment. I also completed a yellow card to report her adverse drug event. Within terms of employment, prescribers are covered by vicarious liability. This means that an employer can be held responsible by the courts for the actions of his employees where there is a link between the act of wrongdoing and the contract of employment. Criminal law covers cases where prescribers had a duty of care and were negligent, and civil law covers disputes where an individual has suffered loss or harm and makes a claim for redress. The legal standard of care is defined under the Bolam test, which essentially means that a prescriber is judged against the standard of their peers. Prescribing off licence is seen more commonly now, more so in areas such as palliative care. The general reasons are that a drug is known to have benefits in a specific condition, but that isn't the condition it was initially licensed for. NICE now include unlicensed medication in their evidence summaries, as there's usually good qualities of evidence to support their use. Ethical considerations. Older adults can experience inequality of treatment when it comes to getting access to healthcare services and in the standard of care provided. This can happen because of physical communication and other barriers, or a lack of knowledge and understanding about the specific needs and concerns of older people. The Mental Capacity Act 2005 provides a statutory framework to protect individuals and provides a clear framework to determine a person's capacity. Prescribers have a responsibility to ensure that patients understand the medication prescribed. In Mrs A's case, the fact that she contacted me as per our plan demonstrates she had good understanding and felt that we were working collaboratively. Commonly, ethical issues arise when a non-medical prescriber must justify a prescribing decision for an unlicensed medication. As well as personal beliefs, prescribers must also consider relevant ethical codes. The role of professional codes of ethics is to offer guidance to prescribers from the Nursing and Midwifery Council and the Royal Pharmaceutical Society. They have certain advantages over general ethical theories in that they are specific to professions and offer more specific advice related to practice. The availability of the primary care prescribing analyses and cost, known as EPACT in my local area, which is the data about prescribing, has led to an increased understanding of costs, but in relation to ethics, there may be situations where budgetary restrictions and local formularies prevent some medicines being available. For example, different trusts taking different decisions about what medicines can be prescribed, and this can lead to ethical concerns for prescribers. In Mrs A's case, colchicine is the first-line treatment, but it's likely if she had another acute attack of gout in the future, this drug wouldn't be suitable, and an alternative would depend on what's available on the formulary. So, safe prescribing decisions and safe prescribing requires vigilance and critical reflection, and it involves an ongoing process of self-awareness to ensure that diagnostic reasoning skills stay current. Key learning points include the World Health Organization's suggestion that for most prescribers they will have a personal formulary. This is a concise list of 40 to 60 drugs that they routinely prescribe. And while this was drafted in 2004, there's some validity to it today, as it offers a sensible way to scope one's practice and determine one's area of expertise. I feel in my future practice that treating acute gout attacks will be within my scope of practice. Further long-term prescribing considerations would be to look at Mrs A's other medication and review if any may have contributed to the gout, and whether doses or medication can be adjusted or changed. Following on from this, in my new role as a prescriber, it will be imperative to have a robust support system in place to support personal development to ensure prescribing based on clinical evidence, clinical suitability, and cost effectiveness. Thank you. And I have 2 reference pages. That's the first one and the second one. Thank you very much.